everyone, and welcome to the AHP Discovery Hub. So we have an amazing presentation for you today, and we have an amazing panel of guests, all virtually joining us today. And just so that you're aware, we are all on Twitter. I know it's maybe not the social media platform of choice, but we have given you our account. So please do follow us, and please do give us some feedback and engage with us on Twitter where you can. We obviously also have the hashtag for all of the social media platforms. So on all of the slides that is available. So again, please do engage as much as you possibly can do. So what do we have in store for you? Well, we are going through today a cancer patient's journey. So Rhea Crighton has very kindly shared her experience of being a cancer patient. And Hazel and I, in our role as Macmillan Therapeutic Radiographer Clinical Fellows, are going to talk you through her journey and how other healthcare professions have impacted on her experience. So my name is Jo McNamara. I'm a therapeutic radiographer, and I'm also a senior lecturer at Sheffield Hallam University. And as part of that role, I teach across all of the health and social care courses. I do course leadership and admissions. So hopefully that gives me some insight into the workforce, and also for you guys thinking about entering a healthcare profession. So we'll talk about that as we progress through the presentation. So I'm going to hand over now to my colleague, Hazel, to introduce herself.
Oh, thanks, Jo. So my name's Hazel Pennington, and I'm also a therapeutic radiographer. I'm a radiographer at the Christie service, and along with Jo, I've been doing a secondment with Macmillan, and we are the very first AHP Clinical Fellows at Macmillan. The fellows have been doctors, so we're really today. So I'll just hand over to Jo now, who's going to talk about what is cancer.
Okay, so it's worth noting, as part of the presentation today, there are 14 allied health professions, and unfortunately we won't be able to cover all of them. However, we will acknowledge that all allied health professions contribute towards the care of cancer patients. So what is cancer? So oncology is another word for cancer. We like to use lots of medical terminology, make ourselves sound a bit more intelligent, but it can also be referred to as a tumour. So 1 in every 2 people are diagnosed with cancer at some time in their lives. So I am sure the audience will know someone or have experience of having cancer. Cancer can be diagnosed and detected in a variety of ways. Typically, patients will go to their GP with symptoms or a sign that could indicate that they have cancer. And then from a GP's perspective, they will have to identify whether or not that could potentially be a cancer or whether it is some other form of condition. So what we would traditionally do is then look at diagnostic tests to actually decide whether or not that is something that is a cancer and needs treatment, or whether it's something else. Now, it's very easy to think that lots of people get cancer, and yes, they do, but the traditional GP will only actually refer 8 cancer patients per year. And so it's important for us as the general public to be aware of what signs and symptoms there are of cancer. So any lumps or bumps, any bleeding, that can all be an indication potentially of a cancer. And so we would always advocate for anyone to actually look to go to their GP and get some investigations. So you can see from this image, through all of the 4 images, that there's lots of things that we would traditionally look at from a cancer perspective. They're all very different. So I'm going to talk you through these images just a little bit. So the top image that you can see there is of a lady's chest. So she's actually got breast cancer. And you can see there's quite a nasty looking tumour there starting to come through the chest wall. And that's actually what we call a fungating tumour. Now, thankfully, we don't see lots of patients presenting like this anymore because of cancer screening. So public awareness of cancer is much more. So if someone were to do a self-examination and feel a lump or a bump, hopefully they'll go to their GP and get diagnosed quicker. But years gone by, that wasn't necessarily the case, and people wouldn't trouble their GP with lumps and bumps. And then they would progress to such a stage here where you can see that the tumour has started to actually come through the skin wall. The other image that you'll see that we've got a big black arrow pointing to, that's actually a CT scan there looking through someone's body, and you can just see the tiny little bit of a kidney there. And behind the kidney, you'll see that there's some white white areas, and that's actually your vertebra. And you can see the arrows pointing to a little bit of grey. That's actually a tumour that started to erode the bone and has actually then started to compress the spinal cord. And that's where we see clinical emergencies arising as a result of cancer. So that would be a spinal cord compression and would need treatment very rapidly. The other image that you can see, again, is a sliced image through the chest, and you can see we've circled there what is a tumour called a mesothelioma tumour. And that actually develops as a result of asbestos exposure. So we know that there are certain carcinogens that actually mutate the cells within our body and start then to cause cancer. So from this perspective, we know that asbestos is a carcinogen, and this person used to work as a plumber when he was very young, obviously had exposure, and then some 20 years later went on to develop mesothelioma. So we know things like smoking, poor diet, sunlight, these are carcinogens that we know will go on to develop into cancer if they damage DNA within our cells. And then we come on to the final image, which I have to say is my favourite, and my son always cringes when I say about how tumours are my favourite, but actually it's a really important point to make, that our knowledge and passion for oncology and cancer allows us to learn more about tumours, how they arise, how they develop. And actually we've got a tumour here called a teratoma. And for those of you who are looking really closely, you can actually see that this tumour is starting to grow hair, it has cartilage forming, it even has some teeth. And that's because of how the cells develop, but how the tumours arise from the original DNA. So it's all really interesting and fascinating, and essentially shows us how important it is to think about research, education, and investment in cancer services, so that eventually one day we may be able to find a cure for all cancers. So we're going to progress on now onto our next slide.
Well, thanks, Jo.
Thank you, Hazel.
So what we're going to do now is we're going to actually listen to Rhea and how she was diagnosed with cervical cancer. And Rhea talks about all the different professions that were involved at this stage of her diagnosis. It's important to remember, though, that every cancer patient has a very individual pathway and therefore receives very personalised care. So everybody sees different healthcare individuals. Rhea's story is not everybody's story. This is just Rhea's. So let's hear from Rhea.
Hi, my name is Rhea. I was diagnosed with cervical cancer in December 2016 when my little boy was 12 weeks old and my daughter was 3.5 years old. I then went on to have treatment for that in January to March 2017, which consisted of chemotherapy, external beam radiotherapy, and brachytherapy. So whilst I was presenting with symptoms, bleeding, leg and back pain, abnormal or pain with bowels and bladder, I obviously presented to my GP. I saw my health visitors who were all very supportive and arranged examinations and further referrals. As part of that, I was then referred to the emergency department and then for ultrasound and then colposcopy. So I've met quite a few health professionals along the way. As part of my cancer, I experienced a paraneoplastic reaction. So I kept getting temperatures with no known infection, no known reason for it. So they put it down to the tumour, and all the chemicals that the tumour produces can mess with your body and its controls. And so I was admitted to hospital with really high temperatures and really severe pain. Whilst I was in hospital, I had MRI scan and CT scan. Obviously, it was a really scary time and I was full of anxiety about what was going on and what the results would be. And actually going for the tests themselves were quite anxiety provoking, especially because I was obviously quite poorly at the time as well. I do remember not being told the first time I had the CT scan that I might feel like I weed myself. And I do think that's really important to remember, that for you guys, if you go into diagnostic radiography, this will be your bread and butter. But for some of us, it's our first time experiencing these things. And actually, it's really important to remember that we don't always know what's going to happen. And actually, in that situation, definitely being aware of it beforehand would have been really beneficial, instead of making me think I'm panicking that I was going to damage the CT scan. And then the other times that I've had my MRI and CT, and despite obviously that uncomfortable sensation of having the contrast, I remember everyone being really supportive and everyone being very professional, but also very warm at the same time. And that was really reassuring. It made a difference between something being more stressful than it needed to be, and something that was far more manageable. So from a patient's point of view, that was really important. And although you will go on to become really skilled, knowledgeable health professionals, it's really important not to forget the interpersonal skills, those communication skills, because for the patient, that's the most important thing. Often we don't know what grades you got or how good you are at physics or how good you are at maths. But what we know is whether you make us feel comfortable and reassured and make us feel safe. And that's really, really important. And they're definitely the things that I always suggest to any health professionals that I work with, is make sure that, you know, you always treat the person, not just the patient. You know, improve your knowledge, improve your skills by all means, but always remember the human there, that we're a person and this might be our first time going through these things. And if you do that, you will do well all of the rest of the time. Good luck.
Wow, gosh, that was really emotional, wasn't it? I don't know how you felt, but I think it's important to try and put yourself in Rhea's shoes just for a minute and try and imagine what a scary, frightening time Rhea was going through then. She had a young family, she had a baby, and she had a cancer diagnosis. So really frightening. And I think what's interesting and powerful from Rhea is what an impact the healthcare professionals had during her journey. We'll hear more from Rhea, but what she really puts forward is how important communication and interpersonal skills are. So if you have those interpersonal skills, really do consider a career in the health service. So
Hi, my name is Rhea.
Rhea talked about being unwell, and she had to go to the A&E, accident and emergency department, and had to get admitted as an emergency. Now, Rhea may have had to call 999 during that period, and she would have come across a paramedic. So let's hear from George, who's a paramedic, and he's going to tell us a little bit more about what it's like to be a paramedic in a cancer pathway.
Hi, my name's George. I've just finished a degree in paramedic science, and I'm currently awaiting my professional registration and start work as a paramedic later on this summer. For my perspective, working on an ambulance and as an ambulance clinician in general, I would be involved in the care of cancer patients in a number of ways. Often this is in the acute or emergency care setting, and we might see patients in their home, at their GP practices, or in their place of work. Paramedics and ambulance clinicians are also involved in the care of cancer patients when completing transfers from one hospital to another. Often these patients receive specialist care at specialist hospitals, and they will go there to receive the best care necessary and suitable for their condition. There are a lot of paramedics working with different areas of healthcare, such as GP practices, emergency departments, and intensive care units. And they may be involved in the care of a cancer patient at any point, from a routine appointment through to being part of the medical team that treats and assesses them in A&E, or even in intensive care following surgery. So there's a lot of ways that paramedics are involved in the care of patients with cancer.
Wasn't that interesting to again hear from George? Because I bet a lot of people didn't realise that paramedics don't just work in ambulances, they work in lots of other areas. They work in A&E, they work in a GP surgery, they can work in intensive care. And that's because they have a whole wide range of really excellent skills that are transferable to all these different areas. So yeah, fantastic there to hear from George. So next, we're going to hear from a diagnostic radiographer. So again, we heard from Rhea that she had lots of diagnostic tests, and all cancer patients will have lots of diagnostic tests to work out what is wrong. And Rhea talked about having an ultrasound, an MRI, a CT. So let's hear from our diagnostic radiographer about her role.
My name is Kayleen Datsy-Macedo and I am a Diagnostic Radiographer at Kingsville Hospital in Nottinghamshire. Diagnostic radiographers are a group of registered allied health professionals who specialise in the performing of X-ray, CT, MRI, ultrasound and nuclear medicine. Using a combination of these imaging modalities, depending on the type of tumour or body part, they can be employed to build a picture of any illness, including cancer. Patients on a cancer pathway will have some kind of imaging to identify or monitor the progression of the disease. This imaging is essential in providing a diagnosis to decide on the treatment plan and to assess the success of treatment. This may start with an initial X-ray or CT scan and may go on to more advanced studies. These may include using live X-ray, ultrasound, or CT images to guide needles into a tumour to take samples, which are then looked at under a microscope. This process identifies the exact nature of the sample identified on other imaging like CT or MRI. Many cancer patients will have interval CT scans to check the progression of treatment. Nuclear medicine may be used to check if cancer has spread to a patient's bones. Ultrasound is used to look at the patient's soft tissues, such as liver, spleen, ovaries, and other abdominal contents. Radiographers contribute to lots of different pathways in the hospital, but are essential to the care of every cancer patient. If you are interested in a career in a hospital, enjoy science, and want to work in a team, then consider radiography. Thanks for listening.
Wow, again, fantastic. Wasn't she just great? And what lots of amazing different roles you can do as a diagnostic radiographer. Really interested. And again, teamwork. I think that's what came out. So let's go back over to Jo now and find out what happens the next step in Rhea's story.
Yeah, so we're really lucky that we had a diagnostic radiographer talking about maybe other tests that a patient might go through. In Rhea's case, she had obviously her diagnosis of cervical cancer, but then once you have a diagnosis of a cancer, what you then have to do is go through something called staging and grading. And that's to ensure that we know where a cancer is, how big it is, how aggressive it is, so that we can put together a really comprehensive treatment plan. And as you can see from some of the images here, it shows how we can essentially use diagnostic tests to be able to ensure that we're using the right treatments. So if a cancer has spread anywhere in the body, you might have to have a treatment called chemotherapy that again will go through the body and hopefully mop up any cancer cells. If it's very localized, then you might have something called surgery, and you might then also have something called radiotherapy. So there's lots of different types of cancer treatments that you'll hear about as we progress through the presentation. But there are lots of things that we need to do to be able to actually use the information to then create that treatment plan. One of the images that you'll see on there is actually someone pointing to a very tiny blue mark. Now, Rhea talks about that in the next part of this presentation, and it is really important that you know what that is. And that is a radiotherapy tattoo. So we're not very artistic. If anyone asked me to do a tattoo, I could only do a dot. You would definitely not want me to do anything more than that. No butterflies or anything like that, which I think Rhea even talks about. But essentially, they're the dots that we use to align where the radiotherapy is going. We are so accurate within radiotherapy. We treat within 2 to 3 millimeters of accuracy. So we need those permanent marks. Although we are doing lots of research at the moment to help develop practice to ensure that maybe in the future we don't have to leave permanent marks. So we're going to move now onto our next slide, and we're going to hear from Rhea talk about her treatment planning.
So in order to plan for treatment, I had to complete my staging. So I'd already had CTs and MRI scans, both as an inpatient and an outpatient. I also had examinations under anaesthetic with a consultant. And I then went on to have a PET CT scan. It was a really interesting experience, sitting there in that little kind of room on the mobile, and realizing I was getting kind of filled with radioactive sugar. I'm still waiting for my superpowers to appear, possibly the power to sweeten tea. But I then went on to have my planning CTs done. So once they knew what stage I was and they knew what kind of treatment I'd be needing, what doses, they would then do the planning CT to figure out the doses. And so I had to be measured up. I had to have really rubbish tattoos done. I think as part of these courses, you need to be trained in how to do butterflies and stars and different kind of more interesting tattoos, or just get rid of them completely and find a different way. Once I'd had that done, I then had to have a meeting with the Macmillan Therapeutic Radiographer, who was my consultant. So she was a consultant radiographer, and she met me before my treatment started to make sure that I was aware of side effects, to do consent, and to just make sure that I knew what the process would be, and to sort out all my appointments and the pages and pages and pages of appointments, because I was there 5 days a week for about 6 weeks in the end, so 28 fractions, and blood tests and things like that I needed beforehand, which included blood transfusion. So again, lots and lots of health professionals involved in that process, but the majority of them were the radiographers, both obviously the diagnostic side as well as the therapeutic side. And again, I just found that everyone was just so warm and compassionate. They were really professional, but really warm at the same time. And it made you feel really reassured that they knew what they were doing and that they actually cared about you as a person, that it wasn't just a factory process line, it wasn't just a tick box exercise that they had to get through, that they actually cared about what your results were and what your experience was and what your outcome was, which was really important. Going through something like a cancer diagnosis and treatment is obviously a life-changing event, but the people that I met along the way, the professionals that supported me, made such a difference. But between it being a very traumatic experience or actually being an experience that was very manageable and well supported, and actually at sometimes really positive as well. And I think that's the part that you have to remember, is that you need the knowledge, you need the skills to be able to do all parts of the treatment planning and the diagnostics and then the treatment itself and then the supporting afterwards. But actually what really, really is important are those interpersonal skills, those communication skills, that empathy and that warmth. And that's what allows you to build that rapport with the patient. And then patients are much more likely to be able to manage their treatment, manage their toxicities, get support from you when needed. And that just makes such a difference to patient quality of life and patient outcome. So, just remember that we are that person behind that patient, and you will do exceptionally well and you will be amazing. So good luck in whichever pathway that you choose.
Oh, how amazing is Rhea? Again, just how many investigations and tests she needs. I know it can be overwhelming for any cancer patient going through their journey, essentially because of how much intervention they have to have, the monitoring, the conversations they have with lots of different healthcare professionals. And Rhea showed, didn't she, that despite all of her own personal healthcare knowledge, the thing that mattered most to her was the communication, the interpersonal skills, the care and empathy that those healthcare professionals showed. So hopefully there's lots of take-home messages for you, and thinking about if you wanted to enter a career in healthcare, what attributes and skills is it that our patients are looking for? Yes, you may have an admissions tutor like me going, do they know what it is to work in the NHS? But actually having an experience like this and listening to a cancer patient, what is it that's important to them? Now, I don't want to be biased, but we are now going to move on to what Rhea's talked about, which is a therapeutic radiographer, which is what I am. So they are by far the best AHP professional. Obviously, I'm slightly biased. But a therapeutic radiographer is the only healthcare professional trained to deliver radiation treatments. So radiation treatments, there are lots of different types. So Hazel works in the proton center, whereas I work more traditionally with linear accelerators. So there are lots of different types of radiation treatments, but typically the main one is radiotherapy. And radiotherapy is given to about 50% of all cancer patients at some point in their cancer journey. So lots of people will come across therapeutic radiographers without maybe necessarily knowing who they are. So radiotherapy itself is the use of high ionizing radiation used to damage the cancer cell's DNA. Radiotherapy is highly effective, and uses some pretty impressive equipment. So a linear accelerator costs about 1.6 to 2 million pounds. And there are even some MRI linear accelerators on the market now, which essentially allows us to do lots of really detailed imaging on a daily basis, adapt the radiotherapy, and then treat. So from Rhea, you also heard that she actually had brachytherapy as well. So that's a type of radiation treatment. And actually that's where they put a radioactive source next to the tumour. So we'll hear from a brachytherapy therapeutic radiographer in a short while. So moving on, I just wanted to kind of talk a little bit about the radiotherapy process because it can be quite complex. So a therapeutic radiographer will essentially work within the radiotherapy department, and they will do lots of things before the treatment even starts to make sure that the treatment is highly accurate and effective. So what they would typically do is use a linear accelerator for the treatment, but before that they might use different imaging. So we've heard of the role of a diagnostic radiographer, but a therapeutic radiographer may also use MRI, CT, ultrasound to localize where the tumor is or where it was if they've had surgery or chemotherapy previously. And then what they would do is use very complex software planning, which again, the therapeutic radiographer could do, or a dosimetrist or someone specialized in planning, to then actually plan the radiotherapy treatment to very localized areas. We don't want to treat normal tissue. The more normal tissue we treat with X-rays, the more that we could essentially cause damage to those normal tissues or potentially cause side effects. So it's really important that that doesn't happen. So we need to be really precise, and luckily we have the equipment and technology and software to be able to do that. So we're going to move along now and listen to our Hazel talk about the actual treatment, and also Rhea.
Okay, thank you, Jo. So let's hear a little bit more from Rhea about what her treatment plan actually involved.
So as part of that treatment, I obviously came across many health professionals. So I had support from clinical specialists, consultants, but to be honest, the most support that I had were from the therapeutic radiographers. So I had a Macmillan consultant radiographer who did my pre-treatment visits, who checked in with me with my side effects to make sure that everything was okay. When I was losing too much weight due to the chemotherapy, checking that it hadn't affected the CT planning, that they didn't need to redo it. And that support was just incredible. You know, having somebody who is so knowledgeable and so skilled, who could kind of support you through that treatment was amazing. I also obviously had the radiographers who were doing my treatments. So although I wasn't there very long, the treatments themselves were very short. I was there 5 days a week for like 6 weeks. So I got to know them really well, and that consistency was so important. I got to know them and they got to know me, so they'd ask me questions about how I was, and you know, it was a really good distraction to just chat to people who started to feel really familiar. They made what could have felt like a bit of a factory process line where you're kind of in for your few minutes and then out again, but actually, because of their interpersonal communication skills, they didn't make it feel like that. It became a very personalized experience, and it felt really, what could have been really traumatic experience was actually sometimes really positive, and even fun at times, which is a bit weird to say. So they were obviously very skilled professionals, and they knew what they were doing, and at times they had to be very focused when it came to, you know, setting the radiotherapy up and making sure that I was in the right place and everything. But when they were walking me in from the changing room and taking me back out again, they were, and during as well, they were always checking in to make sure that I was okay, that I was safe, that I was comfortable, that I didn't want to stop at any point, which was really important. It gave me that sense of control, and in that situation you don't have a lot of things that you have control over, so that was really a positive, important part of the treatment as well. I then had the brachytherapy, which I'd never heard of before, and when I looked it up, was quite terrifying looking. But actually, the experience for me was really positive. So I had mine as an outpatient, where I was in all day, once a week for 3 weeks. Going in the morning, I would have my clinical medical oncologist and the the brachytherapy staff who would support me to have the spinal and sedation done with the anaesthetist, and then they would do what they needed to do, putting everything in place, and then go off to my room and be supported by the chemotherapy day staff as well, and then go off for the scan to make sure that everything was in the right place, and then go and have the actual treatment and then have everything removed. Now, that experience itself, when you're stuck in one place for 7-8 hours and you're not allowed to sit up more than 30 degrees, and it's not a pleasant experience, it can be very uncomfortable. It makes you feel very aware of your body and of what's been happening to it. It's very invasive, so for many people can be really, really traumatic, and it can be really difficult. But actually what I found was that the staff that supported me made it that difference between being something really traumatic and something that was actually a really positive experience. All of the staff were constantly communicating with me, checking in with me. One of the brachytherapy staff I remember very, very well, because she's just so funny and actually, you know, made me laugh so much. And at times thought I might dislodge something, or their hard work might be undone because she was making me giggle so much. And it's those interpersonal skills, those communication skills, that ability to build a rapport really quickly in a really stressful environment when somebody's a bit panicked and a bit anxious and on lots of drugs. That is an amazing skill, and that is the biggest part that I remember. You know, I don't remember how skilled she was or how knowledgeable she was, although I'm sure she was. What I remember is the person and how she made me feel like a person and not just a patient. And I think that's really important to remember, that for you, this might become a permanent job that you do all the time, whereas to us, it may be the first time we've ever been through it. And so it's really important that you remember the person behind the patient, and keep that kind of human connection, which is more important than anything else at all. I think from my own personal point of view, I'm not really bothered what you got in your exams, as long as you pass them. But it does bother me whether you can have that conversation where you can put people at ease, and you can make them feel like you really care and you're really passionate about what you do, because it comes through really, really clearly to the patient. So it's an amazing job, I imagine, and it must be an amazing experience to support people through some of the worst times of their lives. And I'm very, very grateful for all of you coming through and maybe becoming therapeutic radiographers and diagnostic radiographers, or other kind of allied health professionals as well. So thank you.
Wow, I think that's the operative word, isn't it? Every time you hear Rhea, you just want to say, wow, she's amazing, really explains what she went through, and you can almost feel the experience. So Rhea talked about a Macmillan consultant therapeutic radiographer. Now, you might think, well, I thought consultants were just doctors. Well, actually, no, allied health professionals can become consultants as well. So these are allied health professionals that work up through the ranks, as it were. They do extra training, extra qualifications, to become very senior and very specialised in their area of practice across the board. And these consultant allied health professionals actually do a lot of the tasks and roles that doctors traditionally did. So it's really expanding the scope of practice that allied health professionals do, and it gives you a lot of job satisfaction. I hear a lot from colleagues. Now, Rhea also talked about it could be a little bit like a factory on a linear accelerator. You can see the picture there on the screen, and that, you know, often the treating 40, 50 patients a day. But again, the importance of interpersonal skills of the treatment therapeutic radiographers makes it feel like you're a human. She brings the human factor in and how important it is. Now, Rhea also talked about having brachytherapy. So let's hear now from Laura what brachytherapy is as a therapeutic radiographer.
Hello, my name's Laura. I'm a therapeutic radiographer and brachytherapy specialist. Brachytherapy involves the placement of hollow tubes or applicators directly into the treatment area. Tiny radioactive sources are then driven into the tubes under millimeter control. Because the radiation is delivered from the inside, we can target the cancer and spare the normal tissues. The brachytherapy team comprises clinical oncologists, radiographers, clinical scientists and technologists, all working together to ensure safe and accurate treatment, ensuring our patients get excellent evidence-based care. Imaging and planning and treatment are often done on the same day, and staff work together to achieve this goal. We are involved in imaging, planning and treatment delivery, as well as radiation protection, quality control of equipment and service development. The role is very rewarding, and teamwork is an essential part of this.
So again, we heard from Laura, just like the diagnostic radiographers, teamwork is essential. And again, we heard lots of different areas you can go into as a therapeutic radiographer, just like there's lots of areas you can go in as a diagnostic radiographer or other AHPs. Now we're going to move on now to something called Operating Department Practitioner, often shown to ODP. Now, these individuals, healthcare professionals, AHPs, are found often in theatres. Now, Rhea didn't have surgery, but she did have examinations under general anaesthetic, and she did have brachytherapy where she was sedated by the anaesthetist. She absolutely would have come across operating department practitioners. So let's hear now from Mark about his role.
Hey, my name's Mark. I'm an operating department practitioner, known as an ODP. So I work in a hospital and I care for a person when they have an operation. There are 3 stages to a person having an operation. First of all, they have an anaesthetic. So an ODP works with a doctor called an anaesthetist, and he gives the patient drugs. So they'll be asleep during the operation and they don't feel any pain and they don't move. The second stage operation is the surgery, the actual operation itself. So for a gynae patient, that'll be a patient who'll be having like the womb removed or their uterus. And an ODP would assist the surgeon. They would hand instruments in, like scalpels and clamps. And when the operation's finished, they would hand in sutures for helping sew the wound up. After the operation, they would then go to the recovery area, where the operating practitioner makes sure that the person's not in any pain, they don't feel sick, and they make sure there's no side effects from the drugs and there's no complications from surgery. And that, very briefly, is what an operating department practitioner is. Hey, my name.
So that's great to hear from Mark, and you can instantly see that any procedure when you're having treatment is a whole multidisciplinary team. So let's move on now in the story.
Okay, so we're
And here
now. Okay, so we're going to hear now from Rhea. So Rhea talks about living with and beyond cancer, and that is something that we're really passionate about as allied health professions. Yes, you want to administer treatments, but actually we also recognise that those treatments come with long-term side effects. And once you have had cancer, you will be on a cancer pathway for the rest of your life. It will be something that's in the back of your mind, even if you're 10, 15, 20 years since having treatment. And I actually had cancer 2 years ago, and although I am absolutely fine, I have no disease left in my body that they know about, I'm still being checked every 6 months, and I also have long-term side effects. And so having those experiences really does show you how important it is to have healthcare professionals that recognise what treatments you've had, the effects that those treatments have had on you, but also about your quality of life. So we're going to listen now to Rhea and her experience of living with and beyond cancer.
Have luckily had no evidence of disease since. However, I am living with and beyond cancer with the some of the long-term and late effects of chemotherapy and radiotherapy. So since having finished my treatment and since I've moved into survivorship or living with and beyond, I have again met multiple health professionals. So I've had scans to check that my cancer has gone and it hasn't come back, that were quite routine to start with as an outpatient. I've then had scans as an inpatient when I've had acute episodes where they've wanted to be reassured that there's no recurrence or no significant changes that need urgent treatment. I've also had scans as an outpatient, again looking to make sure that there's no changes that need any kind of urgent attention, such as sacral insufficiency fractures from the radiotherapy, or any kind of bowel ischemia or bowel changes that may be causing some of the symptoms that I present with. I've also been very, very fortunate to have had an amazing experience of a late effects consultant radiographer, Dr. Lisa Durrant at Taunton. She is phenomenal. The experience that I had with her was extremely holistic, true kind of personalized care. Her skills and knowledge are obviously tremendous. She has so much experience and is so good at imparting her knowledge to other people. The way that she explains things and describes things is really helpful. It helped reduce some of my anxiety around some of the symptoms that I was living with. And the fact that she explained it in relation to the treatment that I had by showing me my planning CT images and relating that to, say, the MRI that I'd had that showed some kind of changes in the spine. And her communication skills are phenomenal. And I think that's the biggest thing, is that feeling of being validated, of being listened to, of being believed. I have had experiences where people have told me that radiotherapy don't cause certain symptoms or certain changes. And actually speaking to somebody who is a professional, who is very knowledgeable about radiotherapy and what can and cannot be a consequence of it, and having them being able to educate you on a level that you understand is really, really important. And has definitely allowed me to self-manage my condition more, and manage my symptoms and be able to put things in place that can reduce the burden of that and improve my quality of life. So all about thriving rather than just merely surviving. And I think there is much more place in the future for especially therapeutic radiographers to be able to set up these clinics and run these clinics, become advanced practitioners, consultants. You have those skills, those knowledge that patients need, and with those interpersonal skills that you'll learn along the way as well and are innate to you, you are definitely best placed to be able to support people in that kind of living with and beyond area. As without you, there's a massive gap. Patients have amazing support when they're being diagnosed, when they're going through treatment. They have clinical nurse specialists, they have consultants, they have radiographers checking in with them throughout radiotherapy. But once you finish your treatment and you no longer have cancer, there is definitely that gap there. And that's where these late effects clinics hopefully will continue to grow. And maybe one day you will be that therapeutic radiographer that is supporting somebody like me, and making sure that we have really good quality of life. It's one thing to be cured of cancer, but actually to be able to go on and go back to a really good, meaningful quality of life is so important as well. And yeah, so that's kind of my experience of living with and beyond, especially with therapeutic radiographers, obviously, as well as diagnostic, having met them to have my scans and procedures done as part of that diagnosis and as part of that kind of surveillance as well. Incredible, experienced, skilled, amazing professionals, and hopefully you will be joining them one day.
And I promise we did not pay Rhea to say any of that about therapeutic radiographers. But it is the case for all allied health professions. For a cancer patient's journey, depending on where their cancer is and the treatments they have, they may come into contact with lots of healthcare professionals. And so even though Rhea's experiences around therapeutic and diagnostic radiographers and the impact that they were able to make to her, I think it's really important to consider that any allied health profession could make that impact for a cancer patient. So moving on, looking at dietitians. A lot of people think that dietitian is someone helping with weight management. However, it definitely isn't limited to that at all, especially within the cancer pathway. And dietitians may be able to provide support for patients, particularly at the start of treatment, if patients are underweight as a result of their cancer or malnourished. So we're going to listen now to one of our dietitian colleagues talk about their role.
Hi, my name is Lorna Wilson and I am a cancer specialist dietitian working within the area of head and neck cancer at the Christie Hospital in Manchester. Dietitians are qualified and regulated health professionals that assess, diagnose and treat dietary and nutritional problems. We use the most up-to-date health and scientific research and translate that into practical guidance to improve health and treat diseases and conditions. We are regulated by law and are governed by an ethical code similar to doctors to ensure we always work to the highest standard. As an oncology specialist dietitian, I help patients at every stage of their cancer journey. Eating well is an important part of everyday life, but is especially important when undergoing treatment for cancer, such as radiotherapy and chemotherapy. As my career developed, I realised I wanted to work within the NHS. However, as a dietitian, there was a huge range of jobs in a wide variety of different workplaces. You can work within the NHS, like myself, private practice, industry, education, research, sport, media, public relations, publishing, and government and non-government organisations. If you love food and people, enjoy a challenge and making a difference, then a career in dietetics could be for you. For more information, please head to the British Dietetic Association website. Thanks for listening.
So again, a hugely important role for a cancer patient. So looking now at another one of our allied health professions, a physiotherapist. So physiotherapists often get associated with sports, and actually they do so much more than just provide support and rehabilitation for sports people. And as someone who originally wanted to be a physio before I fainted when someone tried to manipulate my shoulder, and I knew it was definitely not the career for me, I know just how important it is for physiotherapists along a cancer patient's pathway. And we have respiratory physiotherapists, neurological physiotherapists. Their role is absolutely massive and features across all of the health pathway. So we're just going to listen now to one of our physio colleagues talk again about their role and their experience of working with a cancer patient.
Hello, my name is Enna Rankitsi. I'm a pelvic health physiotherapist and co-creator of On the Frontline AHPs platform. Pelvic health physiotherapists provide specialist treatment for pregnancy-related musculoskeletal pain, as well as disorders concerning the pelvis, bladder, bowel, and pelvic floor muscles. Following surgery or chemotherapy for gynecological-related cancers, patients are at greater risk of developing pelvic floor dysfunction. So that could be anything from issues with their bladder, bowels, or difficulties engaging in sex. Current statistics show that urinary incontinence can affect up to 70% of patients following surgery. As a pelvic health physiotherapist, we provide individualized treatment plans for patients. This can include pelvic floor muscle training and education, a lot of education, whether it be exercise advice, fluid and dietary management, and if required, the use of biofeedback equipment. We also see patients immediately following surgery on the wards to provide post-surgical rehabilitation advice and respiratory physiotherapy, such as airway clearance. Physiotherapists are not often expected to be involved with patients being treated for gynecological cancers, but we can make a huge difference to a patient's recovery and their quality of life.
Again, an amazing role. So we're going to have a look now at the occupational therapist.
Hi, I'm Jenny. I'm a specialist occupational therapist and I work in cancer care. Today I'm going to give you a brief overview of my role and tell you a bit about the role of occupational therapy. One of the core beliefs of occupational therapy is that the activities and the occupations that we participate in our everyday lives have a positive influence on our health, well-being and overall quality of life. But these activities also contribute to our self-identity and our sense of self. For individuals with a cancer diagnosis, their ability to participate in everyday activities can be hampered or limited by either their illness itself or the side effects of their cancer treatment. They can often experience anxiety, breathlessness, fatigue, cognitive impairments such as short-term memory problems or attention problems. They may find it hard to concentrate on activities. They also may experience reduced exercise tolerance or muscle strength, and these can all act as barriers to the person being able to engage in their everyday activities. My role as an occupational therapist is to assess and provide intervention to address these barriers to participate in an everyday life, and thereby enhancing the person's quality of life. Occupational therapists are trained in both physical and mental health, which means that we can consider the whole person and provide a range of physical and psychological approaches to support the patient. Some of the interventions that I may deliver include anxiety management. I may use psychological interventions such as relaxation. I might provide fatigue management. I might provide rehabilitation, either before the person's cancer treatment or during or as they approach end of life. I also provide support with sleep hygiene and helping the people to adjust to their level of health and disability. If you are interested in finding out more about the role of occupational therapy, then please visit the Royal College of Occupational Therapists website, and there's lots of information there that you can find. The website is www.arcot.co.uk. Thank you.
Wasn't that fascinating to hear about the occupational
Hi, I'm
therapist?
Jenny. I'm a specialist occupational therapist.
Wasn't that fascinating to hear about Jenny, the occupational therapist? I know many of you will never have heard of occupational therapists. I can see from Jenny how important they are in the cancer journey, but they work in lots of other areas, not just cancer. So,
Thank you, Hazel. So now this last slide, we've finally got there, so I hope you're still with us. But this is about AHPs providing personalised and patient-centred care. So that infographic in the centre there are Rhea's words, essentially showing what she thinks is important from her healthcare professional team. Every cancer patient will have a different experience, and it's really important that all healthcare professionals recognise the need for personalised, patient-centred care. As a young therapeutic radiographer, I was treating a cervical patient. She was around the same age as myself, and she used to come for radiotherapy treatment every single day with her two daughters. And, you know, her treatment was progressing really well. Unfortunately, her prognosis was poor, and she was actually having palliative radiotherapy. So we were just aiming to improve her quality of life. And one day she came in and she was quite upset. And I said, you know, is it the side effects? Is it the treatment? And she said, no, it's fine. And anyway, I persevered and I built a really good rapport with her. And over the course of the week, actually, she started to open up to me. And she said, oh, Jo, do you mind if we just have a chat? And I said, yeah, absolutely. So we finished her treatment. We went into a private room. And she said, I need your help. She said, I need to write letters for my daughters for their significant birthdays. I want to write them a letter a year to open from their mum. I want them to have a letter from me on their wedding day. And I know I'm not going to be here to provide support for them, but I want them to remember me. She couldn't ask any of her family. It was too emotive. She knew that she wouldn't be able to rely on them to get through the task. And so over the course of her radiotherapy treatment, we sat and we wrote those letters. And I think knowing that you can make a fundamental impact, not just to the patient, but to their family and the quality of life of their family moving forwards, I think is hugely rewarding. For me, there is no better job in the world than being a healthcare professional and being able to make that impact every single day. So I hope we've kind of inspired you to think about a career as an allied health profession. Obviously, we've only shone a light on the very few. There are 14 in total, and they will all contribute some way or another to a cancer patient's journey. So I'd just like to go to the next slide to provide you our email contact details. So if you did want to contact us at all, then by all means, please do link with us on Twitter. And I just wish you every single success for the future. Hazel and I are hugely passionate to be allied health professions, and we hope that you come and join the workforce. Thank you very much. Thanks, everyone. I know we've run over time, so I don't think there's any time for questions or anything, but please do follow us on Twitter and get in touch should you have any questions at all. We're really passionate about being allied health professions, and we'd just like to say a huge thank you to Rhea for sharing her amazing experience and being brave enough to share it with you all today. So good luck, and please do consider a career as an allied health profession.
Absolutely. Thank you, Jo. Good luck, everybody. And don't forget, it's not just about doctors and nurses. Check out all those 14 allied health professionals. Take care and thanks for listening.
Bye-bye, everyone.